So really excited about the fact that we've moved forward with advanced systemic mastocytosis. As you know, that there are 3 subcategories within it. So patients who have aggressive SM, mast cell leukemia, and SM and an AHN, and that group make up 70% of the patients in that group. So within advanced SM. And I guess the biggest change that's happened in the last 3 or 4 years is the use of the TKIs, the tyrosine kinase inhibitors. Midostaurin was licensed in 2016, has been used for patients with advanced SM, and showed us for the first time there was a disease-modifying effect, with patients getting major responses and partial responses. And then just last year, avapritinib was licensed in the US and is second-line licensed in EMA at the moment this year for patients with advanced SM. And the results that avapritinib brought forward were actually, for the first time ever, we were seeing complete remissions of the SM component, which is really exciting. We were seeing patients with pure ASM in a complete remission with their disease. Not only were they feeling better, but there was resolution of their C findings. So the new potent targeted tyrosine kinase inhibitors are making a big change in the way we manage the patients with these diseases and leading to some really good, deep, meaningful responses in terms of pathological responses and have been disease modifying. So the paradigm's now changed. The TKIs are now at the top of the decision tree. You can access a TKI, then that's what you should be doing for your patients with ASM. Cladribine, cytoreductive therapy still have a place, usually cladribine in the rapid debulking of disease, but really TKIs should be your first line. The other challenge actually that we face within the community with the advanced SM patients are those that have ASM and AHN. And as I said at the beginning, the AHN numbers of patients are really large, 70%. And the commonest AHNs are CMML, MPN, MDS overlap, MDS, and MPN. And the challenge with those patients is deciding which one of these components is causing the problem. Is it the SM or is it the AHN? Which one do you treat first? We know that we've got treatments for both. And I think for that, we are now going to be embedding in the mutational profiles, looking at the symptom burden, looking at the c-KIT allele fraction. Currently, our thought process is anything more than 10% is a significant allele fraction, looking at the high-risk mutations, looking at the prognostic scores we now have for SM. So the whole load of things that we have now evolved over the last 5 years that we can embed and make it patient precision medicine, look at that patient and make a decision about where we need to go with treatment. But without a doubt, the TKIs definitely, the new potent TKIs are really changing the overall survival and the response for these patients.